Okay, thank you. So, yes, as Faisal said, my name is Barbara Verrill. I have worked at the Trust for over 15 years now. I work in MSK, musculoskeletal outpatients. So I'm actually based at the Ashton Primary Care Centre. And I work with Dr. Zuster and Rame as they run the pain clinic. And I also work with the Macmillan team because I get sent the patients who have had breast surgery and who have neuropathic pain following breast surgery. I prescribe for them as well. So that's so obviously my prescribing is chronic pain management. So this presentation is just about supplementary prescribing. It's something that if you're a nurse or a pharmacist, you don't usually need to use legally, but for a lot of allied health professionals, they do need to use supplementary prescribing because they don't have rights to legally prescribe some controlled drugs especially. So this is what some of your colleagues might have to use in certain circumstances. So I'm trying to click forward and it's not doing it at the minute. That's it. Okay, so the definition of supplementary prescribing is that it is a voluntary partnership between three people. As Faisal has said, it's the independent prescriber, the supplementary prescriber, who is, for the purposes of this talk, you, and obviously the patient that you're prescribing for. And you need a clinical management plan, a bit of paper to outline what's going to happen. Yeah, thank you. So the reasons for introducing it are fairly obvious, really. You all know in your work as prescribers that it's much more convenient to be able to prescribe for the patient in front of you without having to get someone else involved. So they wanted to make sure that there was a framework around that to enable that to be done safely. Obviously, it's much quicker and easier for patients to get what they need. There's increased patient choice in accessing the medicines. It makes better use of our skills, doesn't it? We're there with the patient, and if you work in an area, you soon pick up what medications are often used, what the dosages are, what the dangers are of different drugs. So if you work in an area, you already know it. So really, the law was just catching up with what was already the knowledge of clinicians. And it means that obviously in our workplaces, we can be more flexible about how we treat our patients. Are you needing to move it forward, Faisal? Yep. It doesn't seem to be moving forward.
Barbara, if you get to the end of your slide and just say next to me and then I'll move it forward.
Yeah, all right then, I'll do that, yes. So, next, please. So, the areas of improvement that supplementary prescribing allowed was management of long-term conditions and also medicines management, medication review, optimization of medicines. It means you've got some sort of ongoing thing that you can keep on looking at. It allowed for emergency healthcare to be given if you've got an independent prescriber there, obviously, but even with a supplementary prescriber, you can, if you've got a plan for someone, then if something happens within that plan, then you can change things according to what's in the plan already. Mental health services are obviously long-term conditions. It allows for unregistered patients to be treated. It makes that easier because you've got some way of keeping a hold on what happens with those patients. And for palliative care, where you've got an ongoing need for treatment. So this was why it was first brought in. And of course, when it was first brought in, everybody was a supplementary prescriber. They didn't have independent prescribers to start off with, because they needed to show that it was a good thing, which obviously it is. Next, please, Faisal. So there's a number of professions who are allowed to be non-medical prescribers. Not all are. And so you'll be aware of midwives, pharmacists and nurses. And then since then, they've added people at the bottom of that list. So chiropodists and podiatrists, physios, radiographers, paramedics, and they update the law basically to allow people who from different, it's going to be useful for them to be able to prescribe, and to extend the scope legally of people being able to prescribe, to ensure that all the objectives are met of being able to treat the patients in the best way possible. Okay, next one, please. So the legal requirements are that the independent prescriber must be a doctor or a dentist. Even if you are an NMP independent prescriber, you can't be the independent prescriber for a clinical management plan. Someone else has to do that. The supplementary prescriber obviously has to be legally allowed to be a supplementary prescriber, as in the last slide, and there must be a clinical management plan, and it relates to that patient. It's not like PDG that can apply to any patient. This is a named patient document, so it would sit with the patient's notes. And the independent and supplementary prescriber have to be able to share access to the same medical record, because obviously you'll be perhaps pulling in two different directions. You need to be able to look at the same information to make any decisions. Next, please. So the independent prescriber, actually, the independent prescriber is responsible for making the diagnosis. As a supplementary prescriber, in legal terms, you wouldn't be expected to make the original diagnosis. So when I first did my non-medical prescribing training, physios could only become supplementary prescribers. They couldn't become independent prescribers. So I went through a 6-month course to become a supplementary prescriber. And then I went through another 6-month course and basically repeated it, because that was the law, to become an independent prescriber. But a lot of the update, as it were, was all about assessment. So the independent prescriber assesses the patient and formulates the diagnosis, and then they decide what the scope of the clinical management plan needs to be in the light of that. And so they obviously have to agree it with the supplementary prescriber and make sure that the supplementary prescriber is happy to prescribe the medications that are on the clinical management plan. Next, please. So the independent prescriber is there to give support to the supplementary prescriber as needed, and they are also their role is to have still a sort of watching brief on what happens with this patient. So they have to carry out a review of the patient at regular intervals. Now, they don't have to be every 5 minutes. It might be once a year. Certainly for some long-term conditions, but the independent prescriber is always part of that agreement. They don't ever disappear off into the sunset. And the idea is that when the independent prescriber does do a review, the ideal would be for the supplementary prescriber to be there with the patient at the same time. Okay, next please. Obviously they have to share the patient's record, they can't keep it a secret. And the independent prescriber is also responsible for ensuring that any adverse reactions, incidents or anything are reported as the employer, obviously the trust, deems fit. Okay, next one please. So this comes on to the responsibilities of the supplementary prescriber. They have to prescribe in accordance with the clinical management plan. So if you're prescribing as a supplementary prescriber, you can't go outside that plan. You can only do what's stated in that. So for physio, say, the law is a bit cranky. I can prescribe legally, I can independently prescribe morphine and fentanyl patches, but I can't prescribe codeine. So I have to get a clinical management plan if I want to prescribe codeine. And I have to do it in agreement with what's written in that plan. The supplementary prescriber is responsible for reviewing the patient's condition and the effect of the medication. Obviously, that's what it's all about. It's about, you know, the responsibility for prescribing has been handed over to you at that point. As long as you stick within the plan, then the responsibility is yours. And you can use the information in the plan to make alterations to medicines or dosages. As long as it's written in the plan, as long as all those variables are in the plan, then you can make those changes as you see fit, considering what the patient needs. Okay, next one, please. Obviously, it's something we all do, but we should be working within our clinical competence and within our own codes of conduct. But in this case, obviously, the independent prescriber is there, so there is a source of advice and information if necessary. We should only agree to prescribe medicines that we know about, which is the same whether you're supplementary or independent. We shouldn't be prescribing things that we have woolly knowledge on. And we do have accountability. Like I say, once you're working within the clinical management plan, you are accountable. It's not a case of saying, well, the independent prescriber has set this out, therefore, and this has gone wrong, therefore it's the independent prescriber's fault. That's not the case. You are considered to be, within the law at least, an autonomous practitioner within the bounds of that clinical management plan. So if you, even if you stay within the plan but make a bad decision that there was some way of avoiding, then you will still be accountable for that decision. Okay, next one please, Faisal. The supplementary prescriber has a responsibility to pass the care of the patient back to the independent prescriber if something happens where basically the clinical management plan is unusable. So if there's something else happens, the patient becomes ill with something else, if the reviews can't be carried out, anything that's written on that plan, if you can't stay within the plan, then the plan becomes void. And so you have to pass responsibility back to the independent prescriber. And obviously, if you feel that you're out of your depth with it, or in any reason, then where you don't feel that you can be doing the patient good by using this plan, you pass it back to the independent prescriber. Okay, next please, Faisal. You're part of this agreement, so you obviously have input into the development of the plan. You also have responsibility to report adverse events, so obviously yellow card scheme and any trust reporting pathways that you have within your area. And if anything untoward happens, then the independent prescriber needs to know. They're part of this agreement. They need to know what's going on at any time. Okay, next, please. So the recording of the plan is the responsibility of the supplementary prescriber. And like all our notes for any reason, they're all legal documents. They should be completed within 24 hours at the very latest of seeing the patient. So yes, that has to be done. Next, please. Okay, so I'm going to talk about the clinical management plan itself, the piece of paper. So it is basically, it sets out everything that will be taken into account and the possible decisions that can be made. Everything is set out on the clinical management plan. If you can't actually get the piece of paper signed and sealed in practical terms, it can be agreed verbally. So, for instance, my clinical management plan will be with Dr. Ramay, who works, or Dr. Rooster, who work over at Tameside, and I'm here at Ashton Primary Care Centre. Now, as long as I've agreed it verbally, and they're happy that I've given them enough information verbally, I can say that that's done. But the clinical management plan has to be documented. Again, I would say at least within 24 hours, and obviously you document that it was agreed verbally. So it has to be done properly. Okay, next, please. So the clinical management plan, basically what it is you're setting out something that as an independent prescriber, all of these things you take into account anyway. You are doing all of this stuff. It's just that you don't have to document it. So you will not be a stranger to what is in a clinical management plan at all. So obviously it's got to contain all the name of the patient, or the demographic type stuff, the illness or conditions which have to be which are to be treated by the supplementary prescriber, the date on when the plan starts, so usually the date when the patient's there with you, and then you have to say when there's going to be a review by the doctor or the dentist. And basically it's a formal document that documents the fact that the independent prescriber and the supplementary prescriber and the patient all agree that this is the plan that is necessary to be carried out. Next, please. It talks about the medicines, the specific medicines or class of medicines. It can be as wide or narrow as is necessary. You can, there are no strict rules about a clinical management plan about how much you can put in it. So for the clinical management plan that I use, it's got, we actually use a tick box to say it's got all the medicines that I might want to prescribe that I can't prescribe legally as an independent prescriber. And so we've just set it up. But the actual medications that I might need to prescribe for that particular patient, they'd be ticked off. So it gives, you can give the supplementary prescriber can have quite a large scope within the clinical management plan. Or it might be that it is just one medication, and you might if you've got a patient who is elderly with other comorbidities, you might actually narrow the prescribing options down quite low. You fit it to what would best benefit the patient. That's the main thing. It has to contain the details of the strength, dosage, frequency, or everything about that medication. So if someone else came along and wanted to know what that patient was having, all the details are there. It's obvious what's going on with this patient. And it has to detail the period for which the drug is being used. Obviously, for chronic conditions, that might be not actually specified completely. It'll be an ongoing thing. But for certain circumstances, you might want to say, right, we're only going to try this for a certain amount of time. In that case, it has to say it. Next, please. It has to contain the arrangement, so it has to say on it how you're going to flag up any adverse events. And so we've talked about how that might be done before. And it also talks, it has a section for specifying when the supplementary prescriber should either seek guidance or refer the patient back to the independent prescriber. And as Faisal has put some little chat notes on, what you'll see is if you've already printed it off, you have a document that's got an empty clinical management plan. So you'll see all the bits and pieces that need to be filled in. But in the same document at the bottom, hopefully you've found it, because it does strange formatting and sometimes it puts blank pages in. But you'll see at the end of that document, there is a clinical management plan, basically with loads of crib notes in it to give you extra guidance as to what goes in each of those sections. We'll have a look at that in a bit. It comes up on the slides later on. Okay, next one, please. So it has to record there the guidance, the evidence, the best practice evidence that gives you the authority to prescribe this particular drug or drugs for this particular condition. So it'll be stuff like NICE and things like that, which actually say exactly that this medication is fit for purpose in this condition. So, for instance, one of the drugs that I might use is amitriptyline for, especially for night pain for patients. Now, prescribing it for pain is not, it's an off-license medication for pain because it's licensed for use as an antidepressant. But if you look at the NICE guides on prescribing for neuropathic pain, it's one of the first drugs you go to. So the clinical management plan would say, I'm using the NICE guidelines, and there I've got direct authority to say, yes, amitriptyline's one of the best drugs to treat neuropathic pain, and so that's a sensible thing to do. Obviously, the clinical management plan needs detailed patient information that comes from the patient record and obviously from speaking to the patient, but you haven't got to write an essay on this patient's condition. What you do need to do, though, is make sure that everything is included there that would have an influence on what you decide to prescribe. So if I'm prescribing for pain, the fact that they've got a fungal toenail infection is not going to particularly worry me unless I find out that it's being treated by a drug that interacts. So it's a case of putting in anything that's going to make sure that I can make a safe decision. But you don't, as I say, you don't need to put in absolutely everything but you do need to make sure that you've gathered all the information you need. And that's actually not always easy. I treated a patient once who had some mental health problems, and I had no access to any mental health records. It wasn't on any documentation that the trust held for her. And she didn't tell me when I invited her to tell me, is there anything else I need to know? Are you, and she didn't tell me. So that can cause problems. So as much as you can, obviously you need to get as much information from your patient as possible and make sure they understand that it's important that you know all about them before you, so you can make safe decisions. Okay, next please. The clinical management plan comes to an end if any one of those three people decides they don't like it anymore for some reason. So the patient can say, blow this for a game of Pong because I don't want to do this anymore. And you can as well, and so can the independent prescriber. If at the time of review by the independent prescriber, you agree actually this is no longer of any use, it might be because it's the medication is no longer needed, or you might need to draw up a different clinical management plan because the situation has changed, but that original one is out the window. If there is just one independent prescriber who is replaced, the clinical management plan has to be reviewed because it goes by the person, not by the role. So it's an individual clinician who is the independent prescriber, not someone who is the latest consultant. It's not someone who's replaced someone in their job. So you have to agree it with the person themselves. Obviously, if the new independent prescriber is happy to agree it, then the clinical management plan can continue. Next, please. So all supplementary prescribers can prescribe just about anything as long as a clinical management plan is in place. And so I've already alluded to the fact that controlled drugs are especially important for prescribing. So I just need to cough. Controlled drugs are especially important for prescribing for some allied health professionals because we don't have legal permission to be able to prescribe those. But off-label drugs, unlicensed drugs, can all be prescribed by supplementary prescribers. I think nurses and pharmacists, independent prescribers, can prescribe unlicensed drugs, but other professions can't prescribe unlicensed drugs. So you have to know the law about your own profession, and it's quite useful, I think, for our nursing colleagues and pharmacists to be able to understand that for some of us, we can't just, even if we're independent prescribers, we can't just prescribe. We do need to get this piece of paper, and it's useful to understand that when you're working within a team. Okay, next please. So I'm going to go on to talk about the value of clinical management plans. And obviously, if you're a nurse or pharmacist, especially an independent prescriber, you may be thinking, well, I never will need to use one of these. And maybe that's true, maybe you never will. And that's absolutely fine. But if you're moving into a different area of work, then legally you may have the right to prescribe this drug that the patient in front of you needs. But if you're not, if you feel that there's any wiggle room in your competence, then it might well be worth getting a clinical management plan, because it means that if you do that, then you've got an independent prescriber who's signed up to it. You've got someone, basically you're getting someone to just mentor you through this, maybe the first few prescriptions you do for this medication. And it goes on to the slide says about new prescribers, obviously. So when I first became a prescriber and I could only supplementarily prescribe, I thought it was a jolly nuisance, which it was in some ways, because I needed to get a clinical management plan for absolutely everything. I couldn't independently prescribe any drug at all. And so everything I prescribed, I had to get a plan and take it to one of the non-acute pain consultants. And so it was a faff, because it took a bit more time and effort. But I must say, because I discussed certain things with them, I learned more than I'd learned when I was actually doing the course, and just little bits and pieces of their experience, which they were very willing to share. It made me a better independent prescriber when I was able to independently prescribe those. So you know, don't think it is just a waste of time. It does make life a bit more difficult, but it does give a platform for a lot of learning. And I think because I had that when I became an independent prescriber, I had that extra level of safety and understanding when I did it. So it wasn't a waste of time at all. Next, please, Faisal. So these 2 points sort of both sides of a coin, really. Supplementary prescribing, if you're using a clinical management plan, it can help to pull together a team of people if they're treating a patient for a long-term condition. So legally, none of the team might need to have a clinical management plan to be able to prescribe the medication that's on there. But from the point of view of ensuring that the patient gets joined up treatment, if everyone signs up to it, then it means that the patient isn't going from one clinician to another with a different opinion. And I have had not many, I must say, but a few patients who've been to the GP who wants to do something. They've been to the consultant who wants to do something else, and that's it. This is just within pain management, and then come to me. And when I've actually sat down with them and worked out what's going on, then I'm thinking that the best thing would be something completely different. So, you know, it avoids that, and it avoids patients being you know, not knowing whose advice to take. If the clinicians all sit down and make one plan, it makes life a lot easier. Next, please. And I've already talked about the fact that some of us are only able to prescribe certain medications with a clinical management plan. If we did it any other way, we'd be breaking the law. And yeah, sorry. So unlicensed medicines, yes, I've already said that, really, that apart from nurses and pharmacists, NMPs, no other NMP can prescribe unlicensed medicines. Next, please, Faisal. This is actually probably already taken care of, but you do need to make sure that within your department that people know who you're prescribing for, so and what you're prescribing. So within my role, I've got some documents lodged with FAE that say who I'm prescribing for and under what particular circumstances. So I wouldn't suddenly take it into my head to prescribe for a different group of people. So it's important for governance that there is some plan as to who you're prescribing for, and it links into obviously being insured. The trust isn't going to be very happy if they suddenly discover that there's a complaint made against you for doing something that they didn't actually even know you were doing. So it's important that that's clear. Okay, next please. So what we're going to get you doing when I've finished whittling at you is we're going to ask you to fill in a clinical management plan, which is why you've been sent the ability to download the paper documents. And like I say, it's stuff you do all the time. It's just you don't normally have to write it. So it shouldn't be too difficult. But it's quite useful. I find when I have to do a clinical management plan, it just makes you remember all the things that you have to remember. And if you're not sure, even if you don't have to fill in a clinical management plan legally, it's actually quite a useful document anyway, because it gives you a checklist of all the things you need to just make sure that you've confirmed and worked out with this patient to make sure that your prescribing is going to be safe and effective. So the clinical management plan's got obviously the name of the patient, and then you want to make sure that they haven't got any allergies or any other sensitivities. It's just all the things you would normally go through, what current medication they've got, any over-the-counter stuff, medical histories, all the history that's relevant to your prescribing. Make sure that you try and get all that information out of your patient if you can. And then it has things like the independent prescriber, the supplementary prescriber, so that because you're the people who are going to sign this document to say that you're agreeing to it. And then it has to detail the conditions to be treated and the aim of treatment. So, you know, you might have a patient with a number of conditions in front of you, but the clinical management plan is about either one or two conditions, or it can be however many, but they have to be stated on this plan. You can't discover a third condition and think, right, I'm going to prescribe for that as a supplementary prescriber. And then the aim of the treatment is obviously whether you want to prevent something, to maintain something, or fix something if possible. Okay, next please. And then the clinical management plan has to have the details of the medication, so the specific medication or the class, the reason why you're giving this medication, and then the dose schedule. So what I've suggested there is that if you quote the BNF, then even if the BNF's recommendations change, the clinical management plan doesn't have to change. The clinical management plan stays up to date, because you can just go to the up-to-date version of the BNF online. However, if you want to specify the range of dosage, for instance, and you're not really caring what the BNF is going to say in the future, obviously we should be sticking to what the BNF says, but if you're wanting to stick to quite a strict regime of dosing, that goes in there. So the clinical management plan is gives the boundaries for prescribing. And then the indications back to the independent prescriber. And again, even if you can prescribe a medication independently, there are there might be situations where you're thinking, actually, this isn't going according to plan. I need to ask for support and advice in this case. So these are the sorts of things, that you might ask for support from somebody with perhaps more experience than you in this particular area of prescribing. But in a clinical management plan, it has to be something that's quite specific. It can't be so woolly as to be able to say, well, I'm not quite sure. And so within my clinical management plan for pain management, it's a bit difficult sometimes. So what I think I've worded it something along the lines of that I'm unable to prescribe to allow the patient's pain to be well managed. And I've put well managed will be defined by the patient, because there's no other measure of pain than what the patient says, but it has to be as specific as possible. So if the patient's saying to me, look, I'm not coping, I need some more help, and the clinical management plan doesn't allow me to optimize their medications within its boundaries, that's when I'd refer back to the independent prescriber. The guidelines or the protocols there's that space for your NICE guidelines and any local guidelines, GMMG, all that sort of stuff goes in there. Next, please. And so this is the last bit of the clinical management plan. So how frequently is review and monitoring? So the supplementary prescriber has to agree to review the patient on a regular basis. If you're going to see a patient for a long-term condition and you need to see them every 6 weeks, then you might want to put 7 weeks down to make sure you stay within the clinical management plan, as long as 7 weeks wouldn't be dangerous, obviously. So you're allowed to put in those spaces times that actually work. You don't have to put in times where you think, oh, I'm going to be on the limit every 5 seconds. The process for reporting any adverse reactions, and then you have to document what shared resource you're using for the patient's history. That has to be there, all the patient's information. And then the last bit is the signature of the independent prescriber. It says, obviously, within 24 hours of a documented verbal agreement. The supplementary prescriber has to sign that. The patient doesn't have to sign the agreement, but obviously you have to document that the patient has agreed to the agreement. And if you want to get the patient to sign it as well, there's no harm in that. But the patient needs to be aware that that document exists, and you have to document that they've verbally agreed. Okay, so I think the next slide is the last slide, and it's just some information from various websites that I've that might be useful. The HCPC at the bottom there is the Health and Care Professions Council, and all the allied health professionals are registered with them. But it's useful information if people need to know what the legalities are about what can be prescribed as a supplementary prescriber or an independent prescriber.